I think, we have quite a number of medicines that are approved in MS, but they're starting to mature, in essence, in their data. Several of them have been out for 2 decades, and several have been out now for several years. So we're starting to really get longer-term data for our more recently approved medicines, and so they're still new to us, but now we have the comfort of several years of extension data to look at consistent efficacy, to look at safety and side effects, and that's actually moving the field towards a more comfortable place with these agents. Well, it's interesting. I think all of the medicines that are approved were right to be approved. It has become a challenge of picking the right medicine for the right patient. It's a great problem to have in our field. We didn't always have that problem. So we've seen long-term data for several medicines at this meeting. One that I'm presenting is alemtuzumab, which came out a couple of years ago now, but is somewhat different than our other medicines in that it's infused for a series of courses for just a few days, a year apart. And so now we can follow these patients out for several years and see what's the longer-term effect of that brief 2 courses of treatment over the long term. So I'm presenting some data from that, from the 5-year outcomes of what we call the highly active patients with an excessive amount of relapses and enhancing lesions treated with, in this case, alemtuzumab. We found that 68% of these patients didn't need to be treated again after that 12-month dose. And we followed them out for 5 years, and they continued to do very well. Very low relapse rates, very low recurrence of MRI disease activity, very little disability accumulated. In fact, the overall disability scores are better at 5 years than they were at the beginning. I mean, this is a medicine that really needs some thoughtful consideration around starting it. It does have a risk profile and a monitoring requirement that is robust. So we think about monitoring blood and urine tests monthly. Patients have to understand that, monthly for 4 years. They need to understand the risks of infection, risks of autoimmune diseases. So there's a lot of patient education that goes on. So I look for patients who have disease activity, and I think they warrant or they need that kind of powerful treatment, but also patients that are otherwise healthy enough that they can tolerate it and knowledgeable enough to participate in the decision and then in the monitoring so that I can be confident that we can use it safely. Well, I think it was designed to be 2 courses of treatment, and then patients could be retreated if they needed to be. And so, as I said, in our 5-year cohort here of the highly active patients, 68% didn't need to be retreated at 5 years. That means 30 or so percent did get retreated, which is sometimes necessary. I think that no matter what, the treatment of MS is a long-term commitment, so I don't think we're ever going to have a true one-shot and done. I mean, this is a chronic disease, and the needs persist even in patients that don't have relapses. We have to watch for more subtle changes on their MRI scan. We watch for disability to accumulate, and we have to watch for side effects and adverse events. So it's hands-on all the way through, but I definitely think it's desirable to have medicines that work for a long time. We could also make the argument that medicines that are dosed all the time, as long as they work consistently, and as long as they work all the time, and don't have any new emergent safety signals, that's an effective strategy too. We've seen some of that here at this meeting also. Teriflunomide, one of our oral pills given every day, now has data out beyond 12 years from the phase 2 trial. That's been great. Fingolimod, another one of the oral medicines, data out past 6 years. No surprises, and definitely maintains efficacy in the right patient. So I think that's been assuring also.